In this short lecture, we will discuss the esophagus. Firstly, there will be a short recap of the anatomy. Patients may refer to this as our food pipe or gullet. Sometimes when discussing things with patients, it is appropriate to use more informal language and descriptions alongside correct medical terminology to aid in their understanding. The esophagus begins at the throat and travels to the stomach, passing through the diaphragm en route. The length is usually around 25 centimetres in adults. It passes behind the trachea and in front of the spine. There are two sphincters in the esophagus. The upper esophageal sphincter is under voluntary as well as involuntary control. It functions to prevent food and liquids from entering the trachea, in other words, preventing food from going down the wrong way. This can be opened and closed consciously, as during burping, swallowing and vomiting. The lower esophageal sphincter is not under conscious control and works to prevent stomach acid from travelling into the esophagus. Alcohol, as well as several types of prescription medications, can cause relaxation of the LES, leading to reflux. The esophagus has 4 layers. The mucosa is the inner layer. It is moist to help food pass smoothly into the stomach. The submucosa contains glands that produce the mucus. This keeps the esophagus moist. The muscularis is the muscle layer. It pushes food down into the stomach. The adventitia is the outer layer. It attaches the esophagus to nearby parts of the body. The function of the esophagus is to pass food and liquids from the mouth down into the stomach. This is accomplished by periodic contractions, peristalsis, instead of gravity. With vomiting, these contractions are reversed, allowing the stomach contents to be returned to the mouth and to be spat out. There are around 9,300 new esophageal cancer cases in the UK every year. That's 25 every day. Esophageal cancer is the 14th most common cancer in the UK, accounting for 2% of all new cancer cases. In females in the UK, esophageal cancer is the 15th most common cancer, with around 2,800 new cases every year. In males, esophageal cancer is the 9th most common cancer, with around 6,400 new cases every year. Incidence rates for esophageal cancer in the UK are highest in people aged 85 to 89. Each year, around 4 in 10 of all new esophageal cancer cases in the UK are diagnosed in people aged 75 and over. Since the early 1990s, esophageal cancer incidence rates have increased by around 4% in the UK. Rates in females have decreased by about 16%, and rates in males have increased by around 11%. Most esophageal cancers occur in the lower third of the esophagus. Incidence rates for esophageal cancer are projected to fall by 3% in the UK between 2014 and 2035 to 18 cases per 100,000 people by 2035. Esophageal cancer incidence rates in England in females are 43% higher in the most deprived quintile compared to the least, and in males are 50% higher in the most deprived quintile compared with the least. Around 1,200 cases of esophageal cancer each year in England are linked with deprivation, around 320 in females and around 890 in males. Incidence rates for esophageal cancer are lower in the Asian and Black ethnic groups compared with the white ethnic group. Almost 1 in 2 of people diagnosed with esophageal cancer in England survive their disease for 1 year or more. More than 3 in 20 of people diagnosed with esophageal cancer in England survive their disease for 5 years or more. It is predicted that more than 1 in 10 of people diagnosed with esophageal cancer in England survived their disease for 10 years or more. Esophageal cancer survival for females is similar to males at 1 year and higher than males for 5 years. Almost a fifth of men and more than a quarter of women in England diagnosed with esophageal cancer aged 50 to 59 survive their disease for 5 years or more, compared with around 5 in 100 people diagnosed aged 80 or over. Esophageal cancer survival is improving and has tripled in the last 40 years in the UK. In the 1970s, less than 5 in 100 people diagnosed with esophageal cancer survived their disease beyond 10 years. Now it is more than a tenth. When diagnosed at its earliest stage, more than 8 in 10, so 84% of people with esophageal cancer will survive their disease for 1 year or more, compared with around 1 in 5 people when the disease is diagnosed at the later stage. Although these statistics relate to England, the numbers are very similar UK-wide and indeed in Scotland. There are two main types of esophageal cancer. Adenocarcinomas are cancers that develop in gland cells. These cells make mucus in the lining of the esophagus. This is the most common type of esophageal cancer in the UK. It is more common in men than women and is linked to being overweight and having a long history of acid reflux. Esophageal adenocarcinomas mainly affect the lower part of the esophagus. Squamous cell cancers develop from squamous cells that make up the inner lining of your esophagus. This is the second most common type of esophageal cancer in the UK. It is linked to smoking and drinking alcohol. Squamous cell cancers tend to develop in the upper and middle part of the esophagus. The most common symptoms of esophageal cancer are trouble swallowing, chest pain, weight loss, hoarseness, chronic cough, vomiting, bone pain if the cancer spread to the bone, and bleeding into the esophagus. This blood then passes through the digestive tract, which may turn the stool black. This slide shows an endoscopic image of the esophagus. Some of it looks pink and healthy, but there is a small tumour on the right-hand side, and the area of inflamed and rough tissue shows Barrett's esophagus, a condition which causes a change in the cells of the lining. This increases the risk of esophageal adenocarcinoma. It is thought to be linked to long-term indigestion and heartburn and gastroesophageal reflux disease, known as GERD. The image on the right shows the TNM staging of esophageal cancer. The most common spread of esophageal cancer is to the liver, the lungs, and lymphatic spread. Here we can see a table of the most common risk factors for esophageal cancer, split into the squamous cell cancer and the adenocarcinoma. There are interesting differences here between the two types and not a huge amount of overlap. The main risk factors detailed by the NHS state obesity, high-fat diet, excessive alcohol, and smoking. These are all lifestyle factors. As part of the investigation into a patient with suspected esophageal cancer, they will often go through an endoscopy with biopsy and some imaging investigations. Here you can see a barium swallow X-ray where you can clearly see the pool of liquid and the stricture below. A contrast CT of the thorax where the tumour is surrounding the entire esophagus, and an MRI showing a large tumour. One of the main choices of treatment is surgery. The two most common procedures are the insertion of a stent to widen the esophagus narrowed by the tumour, or an esophagectomy where part or all of the esophagus is removed and then reconstructed using the stomach. Both of these are very invasive and require a lot of recovery time and lifestyle modification. Patients then may go on to have other treatments as well. There are various types of chemotherapy drugs that can be used to treat esophageal cancer. 5-FU or capecitabine are the ones that you most commonly hear, alongside cisplatin, or sometimes even carboplatin. Chemotherapy can be delivered before or after surgery, and it's often done in conjunction with the radiotherapy. In recent years, NICE has approved the use of immunotherapy drugs, and they've been proven to be very effective for both types of esophageal cancer, slightly more so for squamous cell, but definitely worthwhile and vastly improved the outcomes for a lot of patients. For radiotherapy of esophageal cancer, we must first consider our mobilisation devices. If the patient has a lower esophageal tumour, i.e. one that's near the stomach, we would consider using a wingboard. This ensures that the patient's arms were kept up and out of the field. We would tattoo this patient about the level of xiphi sternum, for nice, easy CT references. If the patient wasn't fit enough to put their arms above their head, or indeed if they had an upper esophageal tumour, i.e. one nearer the mouth, they would most commonly be treated using a BDS. The patient is planned using a CT contrast scan, and then using an eclipse planning system to produce a VMAT plan. The images on the right show the dose that might be received by the surrounding structures. When treating esophageal patients, you can see that there is many organs at risk in the vicinity, and this makes planning of them quite complex. Patients receiving radiotherapy can have quite severe side effects. Skin reactions, both outside and in, can cause quite a bit of discomfort. They may also have nausea and vomiting, quite likely to be very fatigued. They may have painful sores in the mouth and the throat and all the way down their esophagus. They sometimes have a dry mouth or thick saliva, depending on how high up the treatment is actually occurring. They may have pain on swallowing, and it may even cause stricture of the esophagus. These patients are likely to receive 50 to 60 Gray in 20 to 30 fractions for a radical, and 30 Gray in 10 fractions, or 20 and 5 for a palliative patient. You can see by the images on the left-hand side, image A shows the tumour before treatment, and image B shows the esophagus after treatment. This is probably taken quite a wee while afterwards, as you can see that there isn't as much irritation or reddening at all. Patients need quite a lot of support if they are receiving radiotherapy. They are likely to be quite uncomfortable and therefore will require different types of pain relief, and they will probably require dietetic advice as well. These patients can become quite ill quite quickly and need to be looked after. They may require quite a bit of care due to the fact they're having chemotherapy, surgery and radiotherapy.